because of the endodontic failure. So he was referred to me, and what I did to save this tooth was very simple. I removed the metal post here, and I obturated the canal with MTA. I intentionally extruded MTA into the periapical tissues, and this is what I got. 3 years after the retreatment, you see the complete periapical healing. And the root was actually longer than before I retreated this tooth. And this is 12 years post-op showing nice periapical healing. This is 17 years post-op showing the same. So don't just extract a tooth because the endo is cheap. Be expensive. Then you want to save the tooth. Everybody can place an implant, but not many people can save the tooth if the tooth is in this condition. But if you are expensive, you will start thinking about saving the tooth. So you must be expensive. You must make money to save the tooth. Because many dentists want to extract a tooth because they want to make money placing an implant. So here, another case. Look at this case here. You see a huge lesion. Look at the size of the lesion. It's huge. And actually, the periapical disease is actually elevating the sinus floor. And this patient was referred to me, and I retreated this tooth. And this is a post-op, 6 months post-op, 1 year post-op, showing nice periapical healing. But you can see still small lesion here. But I waited another 3 months. Now I see complete periapical healing here. So you can save the tooth, even in this poor condition. Another case, you see the broken instrument completely here beyond the apical foramen. Oh, where is my cursor? Okay. Sorry. Okay. Anyway, here. You see this is the broken instrument. Yeah, this is a broken instrument. It's completely outside the root canal. I took it out. I took it out from the periapical tissues, then I obturated the canal. And this is 3 months, already showing nice periapical healing. Another case, you see horizontal root fractures here. Oh, I found my cursor. So here is a horizontal root fractures. You see, this is a CBCT images. You see the horizontal root fracture very, very clearly. Then what I did was simple. I obturated the canals because the fracture, as you can see, under the crest bone. Everything happened in the bone. So that's why if you remove bacteria, you can fix this problem. And this is 3 months post-op, and this is 6 months post-op, showing nice periapical healing as well as hard tissue formation in the defect. Here, you see the big defect. Now they are completely calcified here. And the tooth was completely stable, asymptomatic. 2 years, yeah, you don't see any defect anymore. And the tooth received a coronal restoration, the crown. Then the patient was very happy with the crown. And the tooth was completely functional. And you see the vertical crown fracture like this. So how many of you here would want to extract the tooth in this condition? Please raise your hand. Nobody? So you want to save the tooth? Are you sure? How? How do you want to save the tooth? You are very quiet. So, very simple. You have to make a treatment plan based on the diagnosis. So the most important thing to be successful in endodontic treatment is the treatment plan based on the diagnosis. So I made a diagnosis, and there was no root fracture. So I decided to save the tooth with the empty obturation and the placement of the crown. So this is 3 months post-op, 48 months post-op, showing nice periapical healing. And the tooth was completely asymptomatic. So that's why, as I told you, the most important thing to be successful in endo treatment is making an accurate diagnosis, followed by the treatment planning. But I'm sorry, I don't have the time to show you everything, including the diagnosis and the treatment planning. So I will go to the endo retreatment. But I want to just mention one thing: how do you decide? How do you consider the case successful? Because you need to define the success. Okay, so before that, you have to be very good at making an accurate diagnosis. So that's why many people want to be a specialist. Specialist can make an accurate diagnosis. So what is a specialist? What is the expert? If you look into the dictionary, the dictionary says a person who has comprehensive authoritative knowledge or skill in a particular area like endodontics. So specialists can make an accurate diagnosis, prioritize the treatment plan, and the specialist can solve the problem in a shorter time, very quickly, with effective treatment. So you need 3 things: accurate diagnosis, prioritize the treatment planning, and you can solve the problem quickly, not slowly. Then you are very good at endodontic treatment. So what is the accurate diagnosis? In order to have an accurate diagnosis, you must have understanding of pathologic process, and you must have recognition of disease by means of signs, symptoms, tests, including clinical radiographic examination. Then you can have an accurate diagnosis. What about the definition of success? If you look into the dictionary for success, it says attainment of specific goal. So actually there are, in general, 2 definitions. So when the tooth is asymptomatic, the patient will complain about the pain. However, when the tooth becomes asymptomatic, the patient will be happy. Now you can call that success. However, if you are a dentist, from a dental point of view, the success should be to see the healing on the radiograph. So you must make the periapical healing disappear. So there are 2 definitions. In order to make the tooth asymptomatic, or you need to make the periapical lesions disappear. Or some patient just needs you to retain the tooth. They don't care about the symptom. They don't care about the periapical lesions. So the patient should set a goal with a time limit. So for example, here, can you see the radiograph? Where is my cursor again? Sorry, here. Okay. So here you see the big lesion on the mesiobuccal root, and this is a big lesion on the CBCT, the coronal view. You see the big lesion on the sagittal view, and you see the big lesion on the axial view. I retreated this tooth. I waited 6 months. Now the lesion size was reduced. Look at this. If you look at the lesion here, it looks much, much smaller than before the treatment. But do you call this success or failure? This is my question. What do you think? Success? Raise your hand. Nobody. Okay. Okay. A few. Okay. But you see, as a dentist, you don't want to call this success because you can still see the lesion, right? But the tooth was completely asymptomatic, symptom-free. Okay? So that's why before you start your treatment, you have to make a decision. What is a success to the patient? So you have to have the discussion with the patient on the success, definition of the success. For example, here you see a big lesion again, as you can see. I retreated this tooth, and this is 6 months. The tooth was completely asymptomatic. Completely asymptomatic. So at this stage, here, but you still see a big lesion, but the lesion size was completely smaller than the retreatment. Okay? Would you do the surgery at this stage? Because you see a big lesion. If this patient went to another dentist just for consultations, maybe that dentist would do the surgery because the lesion size is still big. So that's why you have to have good discussion with the patient before you perform the retreatment. So I know, because comparing the size of the lesion with the preoperative lesion size, the lesion size was completely smaller. So I waited 18 months. Now look at the size of the lesion. No periapical lesions existing anymore. You see the complete periapical healing. Look at them. No periapical lesion at all. So waiting, you have to wait for some months or sometimes 1 year, more than 1 year, until you see the healing. I had good discussion with the patient before I initiated the retreatment. So that's why patient agreed on my proposal, on my treatment planning. So the patient was okay, just waiting for more than 1 year without the coronal restorations. So you need to discuss this with the patient. Very, very important. Don't let your patient go to another dentist who will destroy the tooth. Okay? Very important. So making a diagnosis followed by the treatment planning is the most important in endodontic treatment, successful endodontic treatment. So this is the systematic review showing if you wait 3 months after the end of treatment, 40% of the cases healed. Only 40% if you just wait 3 months. But if you wait 1 year, 60 to 70% of the cases healed. If you wait 2 to 4 years, 80 to 90% of the cases healed. Look, even if you wait 2 to 4 years, 10% still not healing. Okay, very important. So that's why you have to talk about the time of healing with the patient before you start your treatment. Very important. So if you wait 6 years, more than 95% of the cases heal. 5% still, not healing, maybe shrinking, but not healing. So you have to discuss the issues you may have with the patient before you start the treatment. So if you go by AAE and the Foundation approved definition of endodontic outcome, when the tooth is considered healed, the tooth must be functional, asymptomatic, with no or minimum radiographic periapical pathosis. So that's why you need to take radiograph or CBCT, but CBCT is better because CBCT shows more lesion than 2D radiograph. How many of you have CBCT in this room? Please raise your hand. 3? Only 3? 5? Maybe 10? Okay, thank you. So, as I told you, there are two definitions, two standards for success. One is to completely remove the periapical disease. In other words, no periapical lesions. The other standard is to make the tooth asymptomatic. So if you look at the tooth with symptom-free, the success rate is higher than the tooth without periapical lesions. So this is a gap. The gap is between 9 and 13%. So remember this. You can make it symptom-free earlier, and the standard to make the tooth symptom-free is higher. So you can tell your patient about this. I can make your tooth symptom-free very easily, but you have to wait longer until the lesion is completely gone. So this is a treatment outcomes. There are 69 studies on the outcome studies. But anything before 1990 are outdated, because they didn't use a microscope, they didn't use the MTA. So we are looking at the studies after 1990. And the gap in the success rate is huge. Look, 29% and 100%. The gap are huge from 29 to 100%. It's almost 70% big gap. So we have to look at some studies with a higher evidence. So we will look at the current best evidence. So there are only 6 out of 69 outcome studies in retreatment. These are the current best evidence. So if you look at them, the gap between the lower success rate and higher success rate is only 16%. So if you want to be in a higher success rate, you have to be very careful and you have to have an accurate diagnosis. So that's why it's very important to make an accurate diagnosis so you can be more successful in the treatment. So again, what I want to say is, if you always do what you have always done, you will always get what you always done. So if you want to improve your success rate, you need to change the way you treat the patient. You know him, right? Mark Twain. He's the writer of the Adventures of Tom Sawyer, 1876. He likes adventures. So now, that's why I want to talk about the causes of post-treatment disease. There are two main causes in post-retreatment disease. One is microbial factor, the other one is non-microbial factors. So let's talk about non-microbial factor. So if you look at many studies on post-treatment disease, there are two factors, as I told you. So if you look at the studies on non-microbial factors, you see foreign body reaction, including true cyst and cholesterol crystals. Why you have cholesterol crystals in the lesion? You will have cholesterol crystals brought by macrophages, because macrophages collect cholesterol and bring it to the lesion, periapical lesion. That's why you have lots of cholesterol crystals inside the lesions. And the cholesterol crystals mediate chronic inflammation, and it will adversely affect or delay healing. You don't need that. So you have to remember, when you see a big lesion, if it's a cyst, you have cholesterol crystal. You need to remove it to get the lesion to disappear. So that's why, in that case, you need surgery. It's difficult to make it disappear in non-surgical way. So if you look at the periapical lesions, they are not always cysts. Actually, the majorities are granulation tissues, 72%. 72%. What about the cyst? Cyst is only 21%. Abscess, 4.3%. Scar tissues, only 2.2%. So if you look at the periapical lesion on the radiograph, they are mainly granulation tissues. This is another study. They collected the root end when they did the surgery, and they discovered the lesion was granulation tissues in almost 95% of the cases. Cyst, only 5.2%. So we are mainly dealing with granulation tissues, and the majority of the causes are bacteria inside here. So if you clean the root canal, your success rate will be, or should be, 95%, because the majority of the lesions are granulation tissues coming from the root canal. But of course, you may have extraradicular infections, but which is very small percentage, like 4% or 3%. And the majority of the cases, endodontically treated cases, were extracted due to poor restorations, 41%. So you have to remember this. Your endo may fail because of the poor restorations, not what you did during the endo treatment. The endo treatment will fail because of the poor restorations. Look at this study. This study is very popular. Many people refer to this study, Lay and Trop, 1995. So this is very important. Even if you did a good endo, but if you place a poor restoration with a marginal gap, your endo success rate is only 44%, below 50. However, even if you did a poor endo, you didn't do a good job in endo treatment. However, if you place good restoration, without any marginal gap, your endo success rate is higher, almost 70%. This is why the coronal restoration is very important. Where the bacteria coming from? Bacteria will not, bacteria usually come from the oral environment. They are not born inside the root canal. You take bacteria into the root canal. So that's why if you have the cap, if you have the crown with a good marginal adaptations, there is no space for the bacteria to come into the root canal. So it's very important to have the good coronal restoration without any space around it. So coronal seal has more decisive impact on the treatment outcome than the apical seal. However, if you look at the systematic review, the overall odds of absence of periodontitis in root-treated teeth with a defective restoration, but a higher quality root canal fillings versus those with a high quality restoration, but a defective root fillings is the same. So this means you need both good fillings, good root fillings, and good coronal restorations, if you look at the systematic review. So that's why, but you have to remember, your job is not just fill the root canal, your job is also to seal the coronal part in order to prevent bacterial ingress into the root canal. Very, very important. Do you do both endo and the coronal restorations? Please raise your hand who do both. Only a few. Hello, good morning. You are very shy or quiet? So, but if you just do endo, make sure your referring dentist plays a good coronal restorations. Very important. Because the endo outcome depends on the coronal restoration. Oh, sorry. So this is a good example. Look at them. You see the defect between the coronal restoration and the root. So that's why I stain the dentin. You see lots of red areas here showing the soft dentin. So I removed it, I retreated in one visit. And this is a study done by Domenico Ricucci, Italy. He examined 39 ovulated roots that have been exposed to the oral environment for more than 3 years. But he found bacteria only in the coronal dentin. He classified the root into 3 sections: the apical 1/3, the middle 1/3, and the coronal 1/3. He only found bacteria in the coronal 1/3 of the dentin. You see bacteria here in the dentinal tubules in the coronal 1/3, but he didn't find any bacteria in the dentinal tubules in the apical 1/3 and even in the middle 1/3. So if you do the retreatment, you need to focus on the dentin in the coronal 1/3 because you find lots of bacteria in the coronal dentin. You don't have to enlarge the root canal in the apical 1/3 because there are no bacteria around this area, the apical 1/3. But you have lots of bacteria in the coronal 1/3. This is very important. Why? Why you have more bacteria in the coronal 1/3? Because you have significantly more dentinal tubules in the coronal 1/3 compared to the dentinal tubules in the apical 1/3. That's why you have significantly more bacteria in the coronal one-third. So focus on the coronal dentin. Very, very important. This tooth was extracted because of the vertical root fracture. But if you look at the discoloration of the root, there's no discoloration in the apical one-third compared to the middle one-third and the coronal one-third. This is because the number of the dentinal tubules in the coronal one-third are significantly more than those in the apical one-third. So this case is very typical of the importance of the coronal restorations. I was not able to reach the apical one-third of the mesiobuccal root canal, but you see the preoperative lesion here and here, and this is the post-op. You see, I was not able to reach the apical one-third here. So I had no choice but to obturate the canal only in the middle one-third. However, you see the healing. You see the lamina dura completely reformed on the root. No more periapical disease on this root. So it's very important. Of course, it's very important to obturate the canal, but it's also more important to place the coronal restoration, good coronal restoration. So here, marginal adaptation as well as the complete removal of caries is most essential because bacteria permeate through the poorly placed coronal restoration. And this will bring to another issue. If you obturate the canal with a garapace and a sealer, and this is a study again done by Dr. Domenico Ricucci in Italy, he showed all the cases allowed bacterial leakage, coronal leakage, if you didn't place the crown, as long as you use garapace and the sealer. Look at them. This is garapace and this is the root canal walls. All the bacteria came down into the periapical tissues because garapace didn't bond to the canal walls. If there's no bonding between the root canal wall and the garapace, bacteria will come in and go into the periapical tissue, creating inflammation. So that's why the tooth will become symptomatic. It's very simple. No bacteria, no symptoms. But if you have bacteria, you have symptoms. Don't let bacteria get out of the root canal into the periapical tissues. Then the tooth will become symptomatic. It's a very simple rule. You need to prevent the bacteria from getting out into the periapical tissues. Then there is no disease. In order to do that, you need the material that will bond to dentin. So that's MTA. Don't use garapace and the sealer in retreatment. Garapace will not prevent the bacteria from going into the periapical tissues. That's why the outcome of the tooth with garapace fillings depends on the coronal restorations. But if you have MTA as a root filling material inside, that will prevent the bacteria from going into the periapical tissues. Another case, this is very, very typical. So this case was done in 1996. I was very, very young. And I was busy. My end of fees are very low at that time. So I had to see many patients in order to make money. So I was so busy, I forgot to place the root fittings. But I did place the post, the metal post. I took a radiograph, and the radiograph surprised me because there was no root fittings. You see the periapical lesion on the root associated with the root. But anyway, I didn't remove the metal post because I did a good job. I used the rubber dam and I cleaned and shaved the root canal without gutta-percha fillings. I waited 2 years. Now the lesion became very small, and this is 16 years post-op. Now the lesion is completely gone, and the tooth was completely asymptomatic without any root fillings here. No root fillings, no gutta-percha. So it doesn't matter if you place a gutta-percha and a sealer or not. Gutta-percha does not bond to dentin. So that's why it doesn't matter if you use gutta-percha or sealer. They don't bond to dentin anyway. So the most important thing is the coronal restoration without any marginal gap. Very important. However, I waited 24 years. Now I saw the dentin exposure because of the grinding and the clenching. She was brushing too much. So now you see the recession of the gingival, and the dentin was completely exposed. Now I saw the periapical lesion again. Even if you had root fillings in here with gutta-percha and the sealer, this will happen because gutta-percha does not bond to dentin. Now I had no choice but to retreat this tooth. So why there is no bonding? If you use zinc oxide usinol-based sealer, you will have shrinkage. Glass ionomer, you will see shrinkage. However, of course, if you use resin-based sealer, they will shrink. However, if you look at bioceramic sealer, they will expand instead of shrinking, and they will bond to dentin. So if you do not want to use MTA as a root filling material, I recommend you use bioceramic sealer with a gutta-percha cone because they will bond to dentin. And in addition to that, MTA will expand. Okay, so that's why there's no gap between the material and the root canal walls. So you need to think about the material, which material you use. So what can be responsible for non-healing cases? So we know that we have bacteria in the coronal dentin. What about the apical 1/3? The root canal in the apical 1/3. Do we have bacteria? We know that there are no bacteria in the apical 1/3 of dentin. The apical dentin, no bacteria, no apical dentin. So if you look at them, this is another case. So you see the root fillings here, little bit extruded, but there is no gap in the coronal 1/3. But you see a big lesion. Why? If you retreated this case, you see the gutta-percha, but you see the defect next to the gutta-percha here. So this is the reason. The root canal is not round. You see an oval root canal. You cannot remove the necrotic pulp tissues with a rotary instrument because the rotary instrument is completely round. If you have bacteria in the defect where that you cannot remove with a rotary instrument, the bacteria will remain after the retreatment. So this is the reason why you don't have healing after the retreatment. This is why you need to use CBCT and the microscope. Very important. Without CBCT, without microscope, it's impossible for me to find the defect like this. So what about any bacteria in the root canal? We don't have bacteria in the epicodentin, but we do have bacteria in the root canal, in the apical 1/3. Intracanal biofilms are present in the majority of cases with large periapical lesion. There are so many studies supporting this. And usually biofilms form on necrotic pulp tissues here, pulp tissues like here. So if you have necrotic pulp tissues remaining in the root canal after the retreatment or even after the initial treatment, the biofilm will grow on the necrotic pulp tissues. So that's why you need to have a good diagnosis and good treatment planning to remove those necrotic pulp tissues from the area that you cannot touch with a rotary instrument. So here, this is another study. 90% of endodontic refractory cases have biofilms surviving the retreatment in the hard-to-reach areas in the apical 1/3, including an isthmus or apical ramifications. So you have to be very, very careful when you do the retreatment. You need to focus on those small anatomical spaces, including the isthmus, the apical ramifications, lateral canals, or these small spaces. Very important. How do you know you have the apical ramifications or an isthmus? Take CBCT. CBCT usually shows those small anatomical spaces. So you need to change your treatment plan based on the finding from the CBCT. Very, very important. In addition to that, the area in the apical 1/3 of the root canal is 3 times larger than that in the coronal 1/3 because of the isthmus or an oval root canal. So that's why you have more spaces in the apical 1/3 compared to the spaces in the coronal 1/3. That's why you need to take more time cleaning and shaping in the apical 1/3. You need good irrigation and good instrumentation in the apical 1/3 because you do have bacteria in the apical 1/3. Very, very important. 3 times more in the apical 1/3 than the coronal 1/3. And 70%, almost 70% of the entire root canal in the apical root canal due to the space being oval rather than round. They are not round, they are oval. That's why you cannot completely remove the necrotic pulp tissues from the apical root canal. So biofilm formation is associated with persistent periapical lesions. So when you see the lesion on the radiograph, you need to consider you have biofilms in the apical 1/3. So you need a treatment plan based on the finding, as I keep telling you this. And Candida albicans, Enterococcus faecalis, and actinomyces were the most prevalent microbes associated with persistent apical periodontitis that do not respond to conventional non-surgical retreatment because of the untouched biofilms surviving the retreatment or the initial treatment. You need the surgery in that case. But I want to suggest another alternative to remove them, but that is MTA. And in addition to the biofilm forming on necrotic pulp tissues, biofilms will grow on Garrapatia and the Sera. So they discovered biofilms on Garrapatia and the Seras. So if you extrude it into the periapical tissues, you will see biofilms on forming Garrapatia extruded into the periapical tissues, like this, like this. So it's no good to use Garrapatia and the Sera in retreatment cases because bacteria love being on the Garrapatia and also necrotic pulp tissues. So it's like if you use Garrapatia and the Sera, it's like you are feeding bacteria in retreatment cases. So it's no good to use Garrapatia and the Sera. So if Phaccaris adhere well to the Garrapatia cones, even with zinc oxide eugenol, which will shrink, or calcium hydroxide Seras, which will shrink. Tissue fluids such as saliva, serum play an important role in biofilm formation on Garrapatia in endodontically treated teeth. So Garrapatia, to make it short, can be a scaffold for bacteria to form a biofilm on. So biofilms are more likely to be present in association with long-standing pathologic processes, including large lesion and cyst. So whenever you see a big lesion, more than 10 millimeters in diameter, probably in a higher percent, you have biofilms there. So extraradicular biofilms was present, according to this study, on the external root surface of treated teeth with persistent periapical lesions. Actinomyces are usually the reason, because actinomyces can grow outside the root canal in the periapical tissues. They can survive the periapical tissues. So that's why you need the surgery to remove the actinomyces. Why biofilms are difficult to remove? Because biofilm have the extracellular polymeric substance outside here. You see the yellow part is extracellular polymeric substance protecting the biofilm community. So actually the macrophage or any host cannot attack the biofilms because of the EPS, extracellular polymeric substance, like this. However, if you see the SEM, this is the SEM of the biofilms, you see the defect here and here. There are spaces that you can use. There are spaces for water channels. Bacteria need water to live inside the biofilm. So if you get sodium hypochlorite into the defect in the biofilms, maybe you can eliminate the biofilm, or you can disrupt the biofilms using sodium hypochlorite. That's why if you use high concentration of sodium hypochlorite, you can get it into the small water channels. Then you can eliminate the biofilm. But not always, because biofilms can be calcified. Okay? It's difficult to remove biofilms, but when it comes to becoming calcified, it's more difficult to remove. So, but somebody is yelling next door. I don't know what's happening. But anyway, so biofilms forming microbes. So what kind of bacteria will form biofilms? There are only three kinds. One is Enterococcus Phaccaris, responsible for the intracanal biofilms. And the other one is actinomyces, forming biofilms, especially outside the root canal, or Candida albicans. So if you look at Enterococcus faecalis, they are responsible for biofilm formation inside the root canal. You find significantly more Enterococcus faecalis associated with asymptomatic cases of the post-operative disease. Failed cases are about 9 times more likely to harbor E. faecalis than cases of primary infections. So you see more Enterococcus faecalis in failed endodontically treated cases. So obviously, E. faecalis are responsible for biofilm formation and also failed endodontically treated cases. So detection rate of E. faecalis was higher in persistent infections compared with untreated chronic periapical periodontitis as primary infections. And what about the extraradicular biofilms? Extraradicular biofilms can also be calcified. And you will see extraradicular infection on cemental surface or in periapical tissues. And they can be calcified too. I will tell you later. So endodontic infection advances when the host immunity level weakens. So here you see the big lesion, as you can see. Here you see the big lesion. You see the cavity reaching the pulp, creating acute pulpitis. However, the patient refused any treatment because she was poor. So she decided to, go home and no treatment. However, she waited 2 years and she came back. And the dentist took a radiograph here, and you see the lesion, the carious lesion was developed much bigger. However, look at the periapical disease. There's no periapical lesion existing anymore because the immunity, the host immunity, actually win the battle against bacteria. And the bacteria inside the root canal changed to maybe E. faecalis. So how do you develop the periapical disease? 61.4% to 84.6% of teeth with apical periodontitis had external apical root resorptions. Because of the inflammation from the host immunity, you will have external root resorption. So this is a biofilm. Against the biofilm, the host responds to it. Then the bone will be eliminated in addition to the root surface eliminated because of the inflammations. So according to many studies, 80 to 84% of the cases you see the external root resorption with the cases with the preoperative lesions. So whenever you see the preoperative lesion, 84% of the cases have the external root resorptions. So as I told you, if you have external root resorption, extraradicular biofilms, it's very difficult to remove. You have no choice but to do the surgery. Otherwise, the periapical lesion continues being there. And if you are not good, if you don't use a Lavaderm, it's easy for you to extrude biofilms or extrude whatever you have inside the root canal into the periapical tissues. So if you have actinomyces inside the root canal, And if you bring your file into the periapical tissues, you will end up pushing actinomyces into the periapical tissues. So this is a study done by Domenico Ricucci from Italy. He found actinomyces inside the root canal, but he found exactly the same actinomyces in the periapical tissues, pushed by the instrument that you used.
Điều gì để chắc chắn rồi đó.
And actinomyces will form biofilms. And this is EPS. This is EPS. Because of the EPS, you cannot remove the biofilms. The host immunity will fight against biofilms, but it's useless to remove the biofilms even inside the body, not inside the root canal, even inside the periapical tissues. It's almost impossible to remove the biofilms because of the EPS, extracellular polymeric substance. And as I told you, the biofilms, even outside the root canal, can be calcified. Once the biofilm is calcified, it's impossible to remove, even with a host immunity. So you see here, the biofilms that are calcified, so it's difficult or almost impossible to remove it. So success rate in endodontic therapies, I want to summarize this. So if you see the initial endodontic treatment outcomes, success rate without preoperative lesions are 88 to 97%. But if you have the case with preoperative lesion, the success rate is from 74% to 91%. So success rate is higher if there is no lesion. Success rate is lower if there is a lesion. What about retreatment outcomes? If there is no preoperative lesion, the success rate in retreatment is between 93% and 97%. What about the success rate with preoperative lesion in retreatment? The success rate in retreatment with preoperative lesions is between 61% and 84%. That are significantly lower than the cases without preoperative lesions. So always be careful whenever you see the periapical lesion, because your success rate will be lower if you are not careful, or if you have no idea what you are facing. What about periapical surgery? Periapical surgery without non-surgical retreatment, is significantly lower, between 44% and 78% compared to those receiving non-surgical retreatment before the surgery, showing from 84% to 95%. So before you consider surgery, you must do non-surgical retreatment to be more successful in surgical retreatment. Very, very important. So I don't know what time should I, 9:30. So I'm supposed to take a break at 10 o'clock, right? So again, so let's move to another subject. So to make it short, so your target in retreatment will be first coronal dentin. As I showed you, you have significantly more bacteria in the coronal dentin. So your initial target in retreatment will be the coronal dentin. Then after that, you do have bacteria in the apical 1/3, in the root canal space here. Like if you have a ledge, if you have a broken instrument, beyond the broken instrument, you may have biofilms in the space where you fail to touch with a rotary instrument. So you do have bacteria in the apical ramifications or aneurysms, or even extraradicular infections here. And the canal, 70% of the canal can be oval in the apical 1/3. So you will not completely remove the biofilms or whatever you have in the apical 1/3 because the rotary instrument rotates completely round. So you have to remember this. So the first thing in the treatment is to remove root fillings, right? So I want to show you how to remove the root fillings. So do you think it's easy to remove the Garapacha? I would say it's not easy to remove the Garapacha filling if you don't know the technique to efficiently remove the root fillings, Garapachas. So why do you have to remove the Garapacha? Why do you have to remove the Garapacha in the treatment? I have already told you the reason why you need to remove the Garapacha. Because of the biofilm formation on Garapacha fillings, as well as the seals. So Garapacha can be easily contaminated. Like this. This is a retreatment case. Here, you see the preoperative lesions. This means you have biofilms. 90% of the lesion, big lesion, persistent periapical lesion, have the biofilm formation inside the root canal or even outside the root canal. But remember, 95% of the cases will heal if you remove if you remove bacteria from the root canal. 5% could be outside the root canal. So in my office, about 5 to 3% of the cases go to surgery. So the percentage that I mentioned are very, very true to me. So anyway, here you see, this is the Garapacha. You see the contaminations surrounding the Garapacha cone. You see the black area. They are bacteria or biofilm formations. So it's not good, even if you see the Garapacha fillings to the working length. It doesn't mean you will have success. You will have healing. So root fillings to the root canal terminus do not always lead to successful outcomes because of the bacteria surviving the treatment. Garapacha does not carry any antibacterial activities. Garapacha can be easily contaminated, as I told you, so don't use Garapacha in the treatment. Contaminated Garapacha remaining inside the root canal or outside the root canal can be a major cause of apical periodontitis. So the success rate is lower if the Garapacha is extruded into the periapical tissues because of the biofilms. So that's why you have to be a little bit shy of the working length if you use the Garapacha fillings. So apical periodontitis starts with necrotic pulp tissues or Garapacha fillings placed in the root canal with surviving bacteria in the in the initial endodontic treatment. So according to the study here, more than 35% of the root canal space was left untouched by the instrument that you use. Debridement of those small anatomical spaces is crucial. So here, you see the space left untouched. Here and here, you see the space between the two roots, here and here. Those spaces were not touched by the instrument that you use. So you have to know the small anatomical spaces, especially when you do the retreatment, because they are the reason why you don't have the periapical healing. So here, you see the Garapacha extruded, I separated, and I waited. Of course, I obturated the canal with MTA, but there was no healing because Garapacha was separated, extruded, and Garapacha carries the biofilm. Now I have Garapalcha-centered infections. So I have no options but to do the surgery. So I took it out without touching the root canal, and this is 3 months after the surgery. This is 1 year after the surgery. Now you see the healing. So Garapalcha itself was responsible for the persistent apical periodontitis in this case. So Garapalcha can be easily contaminated carrying biofilms on the surface. So don't use Garapalcha in retreatment. I keep telling you this, very important. So if you extrude it into the maxillary sinus, then you will have another issue. If you extrude it into the periapical tissues like this, you see the Garapalcha in the sinus cavity here. Now you have chronic inflammation because of the sinus aspergillosis. So if you extrude Garapalcha into the maxillary sinus, you will have aspergillosis. Then you have to remove the Garapalcha again. So never use Garapalcha in retreatment. There's nothing good. If you extrude it, you will have problem. As long as you use Garapalcha, you will have problems similar to this. If you don't use Garapalcha, you will not have any problems. Remember what Mark Twain said: if you do what you have always done, you will get what you did. Okay? As long as you use Garapalcha in retreatment, you will have the results similar to whatever you had in the past. So here, this is a different case. So you see a big lesion. You see the sinus here, elevated by the inflammations here. So I decided to use MTA instead of Garapalcha in retreatment. This is a retreatment case. I intentionally excluded MTA because I knew there was biofilms in the periapical tissues or maybe extra radicular tissues, extra radicular infection on the root surface or in the periapical tissues. I did this on purpose. I waited 3 months, 3 months, look at what I got. You see complete healing in this case. If I had extruded Garapalcha filling into the sinus here, what do you think I would get? I would get another issue, like aspergillosis. So don't use Garapalcha in retreatment cases, especially like this. If you see the lesion in the sinus cavity. So there are 3 methods to remove Garapalcha: mechanical, chemical, or surgical. So I will show you the best technique to remove the Garapalcha fillings. So first, this is what I use in removing Garapalcha fillings. So I use here, this is the hand instrument from the TFRK, the kit, Terauchi 5 retrieval kit. Here, GPR. You see the delta cone. You can hook Garapalcha on the projection here, delta cone. And you can press it against Garapalcha and take it out. This is how I remove the Garapalcha. There is another instrument that I want to recommend from the company called Kohler in Germany. There is a small hook here. If you take a close look at this instrument, this is a small hook. So you can use this small hook to remove the Garapalcha. And this is another instrument with the diamond coating at the tip. So you have rough surface on the tip. So use the rough surface with a diamond coating to remove or scrape the garapacha fillings on the root canal walls. This is how I remove the garapacha manually under the microscope. In addition to that, I always use chloroform to dissolve garapacha. Many people consider chloroform carcinogenic or dangerous, but it's not dangerous. If you go to the state, every university hospital has chloroform, and every endodontist in the United States has a chloroform. So don't worry about it. American FDA has no jurisdiction over dentist use of chloroform in clinical practice and has not proven that chloroform is human carcinogenic. And the use of chloroform, this is a very advantageous. The use of chloroform during endodontic retreatment significantly reduced effercaris responsible for biofilm formation. And chloroform is very effective in softening garapacha, very cheap, and it will vaporize very quickly. So even if you don't need lots of chloroform, you need a drop of chloroform, that's all. And it will disappear in a few seconds. Look at this. This is a drop of chloroform. This is how fast it disappears. And in a root canal, a drop of silicone oil is enough. Not silicone oil, sorry, chloroform. A drop of chloroform is enough. And dentists currently using chloroform as a solvent should feel comfortable as they are in compliance with all known standards. So it's okay. Don't worry about toxic materials. It's not toxic to the human. So this is how I use chloroform. When you have garapachas remaining 3 millimeters inside the root canal, this is a small study I did many years ago. And if you put chloroform inside the root canal, when you have 3 millimeter garapacha cone, and if you agitate it, wait 3 minutes, and the garapacha is completely dissolved, completely gone. However, if you have garapacha remaining 80 millimeters inside the root canal, and you use chloroform, you inject chloroform into the root canal, you agitate it, wait 3 minutes, 10 minutes, 15 minutes, you still see garapacha remaining inside the root canal, even extruded from the apical foramen, and this is the coronal, around the orifice. You see garapacha all over the root canal walls. So it's so difficult to remove the garapacha if you start using chloroform from the beginning. So you need to wait until the garapacha is 3 millimeters remaining inside the root canal. So first, you should use mechanical method to remove the garapacha. And if you have garapacha remaining 3 millimeters inside, now it's time to use chloroform. Like this, I would use first ultrasonic tip to create a space for the XP endo shaper. I mechanically remove the garapacha. When you have garapacha remaining 3 millimeters, then I would use chloroform to dissolve the rest of the garapacha fillings. So this is what I use. I use ultrasonic tip, I use the XP endo shaper finisher, and chloroform. I don't use other instruments. So what is the most efficient technique to remove root fillings? So I have already said the XP endo shaper is very nice to remove mechanically the garapacha fillings. Why I use the XP endo shaper? This is the reason why I use the XP endo shaper. So this, according to this study, the more garbage fillings were removed from the root canal in the apical 1/3 with an instrument with a smaller taper, like 1%, compared to the instrument with 8% or 4%. So if you look at the instrument 5001, that removes the most of the garbage fillings compared to the small size, like a 2508, the big tapered instrument, here and here. So I want to use the file with a small taper. So that is the XP Endo Shaper. The XP Endo Shaper has only 1% taper. So that's why I want to use the XP Endo Shaper. In addition to that, this study showed endodontic retreatment procedure might induce cracks during removal of pre-existing root canal filling materials, possibly due to the large diameter instrument used in retreatment. I don't want to destroy the tooth. I don't want to predispose the tooth to root fracture. So that's why I want to use the instrument with a small diameter and with small taper. So which is the XP Endo Shaper. So as I told you, the taper of the XP Endo Shaper is only 1%. Small taper, 1%. And the tip size is, the most apical part of the tip size is 15 or even smaller because of the delta form. So I use this one because of those reasons. And if you spin it in an oval root canal, it goes right and left, like this, right and left. You can touch all over the root canal walls because of the small taper and snake-like shape, like this. So I want to use the instrument different from the conventional rotary instrument. So that is the XP Endo Shaper. You can use this to remove the garbage fillings mechanically. And if you use the XP Endo Shaper, you have significantly less debris extruded into the periapical tissue than other conventional rotary instruments. It's very good if you do not extrude debris into the periapical tissues during the removal of garbage fillings, because debris can be, actually activate immune system, causing acute inflammation, especially those bacteria negative. I forgot the name of it. Wait a minute. The bacteria carrying LPS, lipopolysaccharide, that is classified into negative bacteria. Gram-negative, sorry, I remember that. Gram-negative bacteria. So gram-negative bacteria carries LPS. LPS is responsible for acute inflammations. So that's why it's not good to extrude debris into the periapical tissue during the retreatment, during the removal of the garbage fillings. So comparison between single instrument rotation system. So XP Endo Shaper rotating at 3000 RPM removed significantly more garbage fillings than Wave-1 Gold or High-Flex EDM rotating at 300 RPM. So it's better to use higher speed, like 3000 or 2500 RPM. So whenever I use the XP Endo Shaper, I use higher speed, higher RPM, like 2500 RPM using the AI motor. The AI motor is the only motor that allows higher speed, that is 2500 RPM right now. So this is the protocol to remove the garbage. So first, use small size orthosonic tip, including TFRKS, creating a space for the rotary instrument Then I will use the XP and the shaper in the space that I created with a TFRKS. Spin it at a higher speed. Then when I see the garapature remaining about 3 millimeters, you don't have to be exactly 3 millimeters. You don't have to be accurate. It can be 4 millimeter, it can be 2 millimeter or 1 millimeter. It doesn't matter. So if you see the garapature about 3 millimeters, it's time to use chloroform. You put chloroform inside the root canal, agitate it, then you will spin the XP and the shaper, higher speed, 2500 RPM, followed by the XP and the finisher, then you will dissolve all the garapature remaining inside the root canal. This is how I remove the garapature filling. So let me show you quickly. So here, this is pre-op. You see the lesion, preoperative lesion. It's not big. I only receive difficult cases because in Japan, there are many good dentists and endodontists doing root canal treatment. So I only receive difficult cases. So here, you see the periapical lesion right here. In addition to that, you see what you see here between the root and the coronal respiration. You see the gap between the coronal respiration and the root. So this is the reason why you see the periapical radiolucency. I removed it, I stained the root with a Carius detector dye. Then I removed the soft dentin. I see it under the microscope. I removed it. Then first I use the ultrasonic. Then I spin the XP and the shaper, higher speed. Then I removed it. Then I do one visit treatment. Then I use MTA as a root filling material, and this is a post-op. This is how I remove the garapature, how I do the retreatment. Okay? This is the same. So let me skip this case. So what about the garapature already extruded into the periapical tissues? Basically, you can do the same technique. So you create a space with ultrasonic tape. Here, right here. Then you will use the XP and the shaper, rotating at 2500 RPM. Try to remove the root fillings in one piece. However, if you separate it, it's not too late. It's not the end of the world. You can still do this. So you will use chloroform again. And you push it, you extrude it beyond the apical foramen. Then you spin it with a XP and shaper or finisher. Then you can dissolve the chloroform that was extruded into the periapical tissues. Because if you use the XP and the finisher, it will expand. If the garapature that was separated from the main root canal, that can be removed with the XP and the finisher, because the XP and the finisher will expand. So this is the XP and the finisher. If you rotate like this, it will expand to 3 millimeters. 3 millimeters. So any garapature within 3 millimeters around the apex can be removed or can be dissolved like this. If the apical foramen is small size, don't worry, it will expand beyond the apical foramen like this. If you compress it, it will expand beyond the compressed point, like this. So if you use the XP and the finisher beyond the apical constrictions, it will expand like this. And if you have garapature around the apex, you will take it in. So I will show you some cases using the same technique. So here, you see the Garapalcha cone extruded into the periapical tissues, into the sinus cavity. I use the same technique. First, I used mechanically, but I took it out in one piece. I was very lucky. All the Garapalcha cones were removed mechanically. That's it. So let me quickly show you. Oh, I didn't have the video for this. I removed it. Sorry. So, but what I did was very simple. I used the rotary instrument after I used the ultrasonic tape, TFRKS. I rotated the XP and the shaper, and the Garapalcha came out with the XP and the shaper. That's it. Another case, you see the Garapalcha extruded into the periapical tissues here. This patient was referred to me by a very famous general dentist who extruded Garapalcha into the periapical tissues. He didn't want to continue doing the retreatment because the patient was very famous politician in Japan, and the politician was very powerful. But I hated him. But hatred has nothing to do with my treatment. So I just wanted to make him painful without anesthetizing the patient. Sorry. Yeah. I do not use anesthesia in the treatment. It's not necessary. Because if I use anesthesia, if I anesthetize the patient will not feel pain. When I create the temperature rise, when I did something bad, the patient will not feel pain. I want my patient to feel pain or complain about what I'm doing. Then I know I will realize what's going on, or did I do something wrong? So that's why I will never anesthetize the patient in the treatment. Anyway, what I did was the same. First, I removed the Garapalcha inside the root canal, trying to remove the Garapalcha in one piece, but unfortunately, it was separated. Here, you see the Garapalcha completely separated. Then, this is plan B. Then I pushed chloroform into the periapical tissues. Then I spin the XP and the shaper, 2,500 RPM. You see lots of blood coming from the periapical tissue. Then I remove the Garapalchas from the periapical tissues. This is the radiograph showing complete removal of the Garapalcha in the periapical tissues. This is the post-op. So let me quickly show you how I did this. So here the Garapalcha. First, you need to make a treatment plan based on the finding. So I was away from the inferior alveolar nerve. So I'm spinning the XP and the shaper, 2,500 RPM. Now I'm reaching the periapical tissues. Now you will see the blood coming out because I'm spinning the XP and the shaper beyond the apical foramen. Now I inject chloroform into the periapical tissues. The patient doesn't feel any pain because chloroform used to be used as an anesthesia. Now this is XP and the finisher because I want to expand the XP and the finisher beyond the apical foramen. You hear nothing from the patient. You see lots of blood is coming out. That's why I cannot show this on my YouTube. If you show blood, you will be banned from showing any video. So now you see Garapacha came out from the periapical tissues. Here. I took it out. And another one. So now I injected more chloroform into the periapical tissue. First, I used the expand shaper, followed by the expand finisher. You are softening the Garapacha and mechanically removing the Garapacha. So it came out. So both Garapacha cones came out. And this is a post-op, and this is a 3 months post-op, already showing nice periapical healing compared to this. So this is another case. So as you can see, Garapacha fillings are already extruded from the root end, also from the perforation here. So I made a treatment plan based on the finding from the CBCT. Then I did the same. So let me quickly show you the video here. So you must make an accurate diagnosis followed by the treatment planning. So this is the expand shaper because it's already outside the root canal. So I'm spinning the expand shaper inside the periapical tissues. So that's why you see the blood coming out. But I didn't anesthetize the patient. But there was no complaint from the patient. Even if you see the lots of bleeding. But I know what I'm doing. I'm not doing this randomly. I know what I'm doing. So I'm not worried about it. Spinning again inside the periapical tissues. Irrigate canal with chloroform. I don't want to use sodium hypochlorite outside the root canal. So this way, you can both dissolve the Garapacha and mechanically remove the Garapacha fillings. So I'm already irrigating the canal with chloroform. So this is the distal root canal. Up and down, up and down. Now this time I use EDTA because I saw it coming out, and some of them already dissolved. Then I took radiograph. If there is no Garapacha in the periapical tissues, I will use EDTA and sodium hypochlorite. I'm not extruding sodium hypochlorite into the periapical tissue. I just use it inside the root canal. But I did use chloroform outside the root canal. You see no Garapacha remaining in the periapical tissues. And this is a post-op. I ovulated the canals with MTA, little bit extrusion, it's okay. And you see the perforation repair with MTA here. And this is a 3 months post-op. And this is 6 months post-op showing nice periapical healing. So I took CBCT. CBCT also shows nice periapical healing compared to the pre-op radiograph and CBCT images. Another case, you see big lesion, huge lesion, Garapacha fillings already extruded like this. However, I separated the garapatas again. So if you see the extruded garapata, you have to be careful. Try to remove the garapata in one piece. But sometimes you will end up separating the garapata from the root canal. Then, look, the garapata is not to the apical extent of the root canal. It's beyond it. So, especially this one, I cannot reach this garapata fillings. So because of that, I had to use a different technique. What I did in this case was, I intentionally extruded chloroform into the periapical tissues. Then I closed the root canals with LTA, meaning I obturated the canals with LTA, with Garapacha extruded here into the periapical tissues. However, I had chloroform inside the periapical tissues. I waited 2 weeks, then Garapacha completely dissolved. I didn't see any Garapacha remaining inside the root canal, inside the periapical tissues. And this is 3 months, 9 months, and this is 9 months, CBCT showing, you see, lamina dura completely reformed around the root. This is a coronal view, you see complete periapical healing, no periapical radiolucency at all. Okay, now it's time to take a break, right? Okay. Okay, so we will take 20 minutes, 15 minutes? 15 to 20 minutes break. Okay. Then I will talk about broken eye removal.
Dạ, em xin kính chào quý bác sĩ ạ. Hiện tại thì công ty em xin được thông báo là bác sĩ nào chưa nhận thẻ đeo và ký tên tham gia thì vui lòng liên hệ bạn Lễ Tân ở ngoài sảnh để ký tên và nhận thẻ đeo ạ. Em xin cảm ơn.
Đi vệ sinh không?
Tao đeo thuốc ngoài kia kìa. Bảo vệ kêu Vân Anh.
Chi?
Vân Anh đấy đâu để uống thuốc đây.
Đây này.
Để thôi, tao bỏ thuốc.